introduction. Yeah, really great to see you all. Thank you for coming along. I'm just going to share my screen. And hopefully now you can all see my title slide. I just have a window that I need to make smaller so I can see you. Okay, so
We can't see your screen. Sorry, Sarah.
okay,
Yep.
let me
There we
try
go.
again. Is that working now?
Yes.
Right. Okay, good. So so here is what I'm talking about, as Kelly just introduced, and I want to start by just saying that I've been trying to work on presenting in what I hope is a slightly more interesting way than the traditional research presentation, and there are a few people who I need to credit with the good bits of that. Any mistakes I will own for myself. But there are various pieces of artwork that you will see throughout the presentation that come from using creative methodologies in my research. And so Daniel, Laura, the community, who I'll tell you more about, who formed the Rewilding Healthcare crew, and Richard have all been instrumental in that. And because of that, I thought I'd start with a piece of co-created audio that was made by Laura and myself with some community partners that really captures the story that I want to talk through with you today. So I'm going to play that first. It's a few minutes long, but hopefully you'll find it interesting and it'll help orientate us all.
And now, the shipping forecast, issued by Cody Dock on behalf of the Rewilding Healthcare Group at 1535, 18th of October, 2024. The general synopsis at this time: there are warnings of failures in handling uncertainties through admissions and discharges, now and later, red-hot cases rising, cooling rapidly, losing identity. Things may escalate, decision not to for a time, pressure falling, relationships in patches, moderate or good. Warnings of gales in unreliable bodies and minds, multiple people, multiple places, multiple pills, rough occasionally becoming severe. Normal needs become cyclonic, mistrust and fear imminent, tied up by circumstances, falling through the cracks expected. Frustrated patients, poor access, moderate concern, 3 to 5 days delay, low morale, people good but systems backing up, pressure building, fragmented, needs rising, burnout deepening. And now the forecast for the next 24 hours. Treasure Island, northeasterly, initially hostile, becoming warmer later. Risk-taking advised, venturing westward, growing closer. Boundaries uncertain, land masses scattered via jagged rocks, visibility fair between pointy edges, hazards improving for now. Not safe but good. Foghorn Lighthouse, waves uneven, rough, occasionally very rough, breaking against stony outcrops. Proceed with care. Recall your childhood, depths unknown with sudden changes expected. Turbulent but navigable with support. Keeping an open mind. Bunny Island, occasional clarity, muddy, centered, obscured at times, drifting towards the connected front later. Self-care indicated, intuition suggested. Moderate to good. Coffee Bean Bay, veering, energy rising, effects variable, intensity good. Land masses forming, bonded to adjacent regions through effective services. Library, postal service, health clinic, open. Communication good to phenomenal. Needs met, good. Middle Island, ancient swamp conditions, surfaces slippery, traction low. Navigation unclear in patches 7 to 9 later. Further risk-taking advised through layers of heavy sludge. General connectivity is increasing with land masses merging. Visibility moderate, accessible, support animals at hand. Good. Central Harbour safe, conditions stable, a refuge amidst uncertain times. Surrounding islands rough cut but resilient, this may escalate. Hidden work getting harder later. Freehand coast, terrain irregular, cut in haste but steady, holds meaning despite imperfections. Clarifying identity. Currents strong but varied, trying to coordinate care teams under review. Island fabulosa, coastal settlements forming, wild and urban, some regions remote, others densely connected. Map in progress, contours evolving, stories yet to emerge. Distinct in character, but shapes ambiguous. Love currents detected, stronger at intervals, occasional lulls expected. Strange caverns to the west, depths murky, not known to us, only known to those who venture. Safe passage recommended for the steady-hearted, connection thread weak but present. Work to be done. Surrounding regions are open and inviting. Support vessels on standby. Big root tree aisle, steady presence, below ground network, mirrors the above, roots stretching deep, stability evident but not without risk. Branches open, canopy broad, balanced, reliable but weather worn. Not safe but generally good. Volcano tree grove, contours ancient, boundaries blending, considered huggable, gaining influence. Warmth, slow-moving but apparent, a touchstone for longer journeys. Storms observed in the distance, branches steady for now but may fall later. Good, occasionally poor. Surrounding waters, calm, occasional strong gusts. Kin persists strongly in collaboration, sovereign yet learning. Map in progress, relationships forming, love currents increasing. Winds and energy variables might leave early, relationships grounded and spreading. And now, for travellers to uncharted waters, the forecast for the next 24 hours. For these unknown areas, pressure dominates, rising, falling, circling. Lives caught up in care, systems not working. Conditions cyclonic, shifting unpredictably with poor visibility and fatigue. Likelihood of whirlpools for a time. Misunderstandings intermittent, but we retain some hope. Murky benefit system, discrimination and hate churn ignored by authorities. Reports of fires and threats ongoing, severe, severe, severe. Proceed with extreme caution. External support strongly recommended. Inclusive routes once mapped out, becoming obscured later. Policy currents grow darker, pulling against progress. Sea monsters may be lurking. Surges of resilience, keep battling on. Conditions unpredictable, missteps to mishaps. Watch for jagged rocks. Cyclonic bay, caregiving duties persist, unrelenting. Noises at night, exhaustion settling in. Getting harder with age. Pressure rising. Winds whirl from all sides, no clear direction buffeting feelings of invisibility and unheard concerns. Progress limited by systems resistant to change. Visibility extremely poor, no immediate clearing expected. Conditions may improve later with active listening, but relationships dissolve like fleeting fog. Possible clearing, slight improvement on the horizon, pressure easing for a time 2 to 3. Progress uncertain but not impossible, shifting but not yet forward. Keep the course steady and hope for calmer waters ahead. And that completes the shipping bulletin for today. We will still be here at the same time tomorrow. Thanks for listening.
And so, I appreciate that perhaps the shipping forecast might not culturally translate, but in the UK, even people who've never had anything to do with shipping or the sea, it's a very iconic rhythm. And a lot of the people I work with recognize it. And that was the offering of a community group, people living with palliative care needs and or mental health needs, recreating their own stories of what it felt like to be interacting with the healthcare system. And we did that piece of work because we were working to the idea that if we want to change things for people who are not well included in our healthcare, we need to change how people think about not just them, but the system as well. So where that takes us is that we know it's often impossible to provide so-called optimal care, but we don't really have good strategies for managing risk in the real life conditions of healthcare. And what we need is to develop a way of having more flexible responses when people have emergent needs, things that are customized to their particular needs. So what I've been exploring both in my research and in the creative elements is how can we rewild healthcare, if you like. And the community group I work with, the picture on the left is a pinhole camera of 6 months' time working with them at Codidoc, that the lines are created by the tracking of sunrise and sunset each day. And Laura is an experimental illustrator who I work with, as we try to embody relationship to model the ideas I'm sharing with you today, working with this community. And I really have, it has been very reciprocal, me learning from them as much as anything they may have learned from me working with them. And when I talk about rewilding, it's not about creating wilderness, but it's about creating space for relationships and accepting that we need to engage in positive risk taking. Things have been unhelpfully lost from the healthcare system with narrow, often transactional definitions or structural definitions of risk and harm. Now, I'm very conscious that I'm speaking to a group of experts, so hopefully you don't really need this slide, but it's here for anyone who will find it helpful about how I am using these different terms and definitions. And the one I just wanted to highlight is when I talk about relationship, this is the definition that's highlighted in pink here, coming from David Jay's work outside of healthcare. I really enjoyed reading his book, if anyone wants a reading list recommendation. That a relationship is about shared understanding, about meaningful use of resource, and willingness to change each other through genuine exchange. And so I am going to draw on the rest of this presentation, not only on the artwork that I've already begun to share with you, but also the ethnographic study that Kelly mentioned in my introduction, where I did work in central London. This is my one slide methods for the researchers among you. We can talk about it in detail later, but I thought I'd keep the methodology light for the presentation. But basically, I started out by saying, okay, how do we look at relationships, the in-betweens for people using palliative care as an example and psychiatry, and including broader mental health care as an example? And I couldn't really find anything good about real life practice. That there's lots of stuff about communication, but actually talking about relationship using the definition I just shared in the literature. So I co-designed my work with members of the public. And then my ethnography was with people all over the healthcare system, interviews and observations. GP stands for general practice, so community care, and along with the other community teams. And AMU is acute medical unit. So in the UK, that's where you'd end up immediately after the emergency department if you're in the sort of general pot, as opposed to going off to surgery or a more specific specialty. And after doing that, and I will talk about this a little bit later in the presentation, I worked with 20 people from those different groups with different roles, different experience to look at how we might generate change, starting out with this question of what could our vision be? What does good look like? And we talked about, is stuff that's happening in the healthcare system safety or sinking? I hope no one's offended by the language in my first picture, but this was created by a patient I looked after, an artist, and she gave it to me as a gift. And it really captured how she felt in the system. I'm sure you don't need me to unpack the metaphor further for you. But we find for both of these types of services in our healthcare that everything depends on relational work. I know you know that. But we have different people in different places. There's lots of boundaries. We're trying to synthesize different forms of expertise. And often what we're offered structurally for safety doesn't really work. It creates harm. The picture on the bottom is the Fastnet Lighthouse, and there's a race there annually. But there was a year, I think it was 1979, when there was a massive storm and a lot of lives were lost. The learning from that, though, from a safety point of view, was that lots of people launched their lifeboats and didn't survive. And this phrase, never step down into a lifeboat, your lifeboat's only safer if your ship's sunk below the surface, was really instrumental in changing maritime safety. And the idea behind it is challenging, what do we think safety actually is? And sometimes it's not always what we think it might be. Or safety for you and me as people might not be the same as safety for the institution's reputation, which is, of course, a tension in our systems. So we are definitely facing brewing storms in the UK, and we have a lot of work around what does integration look like? And I think this is a really helpful focus that some researchers put together about, instead of rearranging, the sort of rearranging the deck chairs on the Titanic type activity, we need to be looking at what actually helps or hinders people in the real work that needs to be done together. And to give you an example of how I do my ethnography, this is a quote, quotes field notes from work being in the acute medical unit and observing people. And I've highlighted some of the language, and just as you skim through it, you can hopefully see how this person is talking about someone is safe in hospital, it's attention, what sort of level of risk, they want to ask what level of risk would someone tolerate. They feel that things are wrong, they've got a real moral dissonance, but they also have this, but I've got to save this life, and they feel this responsibility to fix and save. And we all know that that can't be achieved in a very sort of concrete, institutional way for everybody. And it's not what everybody wants. So, if we are thinking, what sort of things are people putting out as the calls for help? People talk about they spend too much time batting things away because they feel under pressure, rather than thinking, how can we work together around a human being's needs? Making sure everyone is aware of things is a real challenge in the system. People can fall in the in-betweens, and people talk to me about, well, are people safe at home? But actually, are they safe if we admit them to hospital? We don't know. People find the system really difficult to navigate, even resourceful people. And just that, that immediacy of dialogue is often so difficult to achieve within the system. People also talked about a sense that, when the crisis happened, they sort of knew what to do, but they felt it was wrong that they were waiting for the crisis, that they couldn't act at the lower level, as they describe here, significant irritation that was destructive. That family needed to be brought in so that they weren't just losing things down the plug hole. People feel pulled around and they get told different things. It creates unease. And some of the people I've already spent time with here in Victoria have talked about, looking after the people who everyone else says they're too difficult for us, and how do you get help for them? So you can see already that there are various points of tension where we don't have enough slack in the system. And these are things that I think particularly are points of tension for us about how to bring multiple forms of experience and expertise in. Often people find themselves operating in transmission of information, and there's lots of assumptions and checking and chasing rather than actual dialogue. The waiting for crises I've already talked about, but also that the system people feel is driving them to focus on not letting anything go wrong, or at least prove in inverted commas that they tried not to let things go wrong, rather than focusing on actually doing something that might be right or good. And there are so many ways of feeling unsafe. And one of my participants in a workshop here, suddenly gives this quote of realization of, I need to work with the rest of the team. I need to pick up the phone. I need to build relationship. But it's so hard for people to do that within the system. So I'm going to talk throughout this presentation about whole systems approaches. And again, just to clarify, I think you will all kind of resonate with the picture on this slide. But I think all too often in our language, we talk about the system as if though it's separate from people. And actually, the system's integral. We might think that none of us have ultimate power or any power in the system, but somebody is creating the system. It doesn't, it's not a sentient being of its own self. And equally, I think the healthcare system, certainly where I'm based, gets drawn into part system efficiency with overvaluing speed and time and not looking at whole system effectiveness. Now, I'm sure some of you are familiar with this. This is the work of my friend and colleague, Libby Salno, and looks at, whole systems for palliative care. Libby herself calls this her horrendogram, the horrendousness of how complex it is. But all I really want to highlight to you as part of this talk is we have what we call human health, sociocultural and other systems. Every single line on that diagram is affected by relationship, whether it's the presence, absence, strength or weakness of relationship. And yet so often I think we're drawn to looking at what's at the end of each line, not looking at the line in itself. So I feel like I should say this is a especially good example, hopefully, for Fraser, who was talking to me about how bad UK roundabouts were yesterday. This really is a road design. It comes from where I grew up. We all lived in fear of being taken here on our driving tests back at, 17, 18 years of age. But it's to illustrate what I think might be going on in the system, because we all know that good people will try and work around to get the best for others within a system. But I think our feedback loops are broken. And that's because when you're faced with this is what the sign, the design of this roundabout looks like. There's lots of different things that are going on. How do you navigate this? How do you drive around it? And what we're seeing in this is the difference between work as imagined. So the people who designed the roundabout, I'm sure thought they were super clever and they'd found a really, neat solution. But they didn't have understanding of how it was actually done. But not only that, the people driving around it in practice, what are they going to actually do versus what would they declare back to the designers or perhaps the police force when they're asked, what were you doing there? Was that how you were supposed to do it? And then that is also different to what matters, because ultimately what matters is nobody crashes. And actually the roundabout is easier to navigate when it's really busy because everyone just drives really slowly in first gear than when it's all flowing. So we have this kind of dissonance, don't we, between great ideas, how do you do it, what you say you did, and whether you've actually worked it out together as a community. So I'm thinking today with you about how do we go from connectionships to relationships? How do we create containers, maybe those mini roundabouts that are allowing people to express relational agency, having conversations, not just talking about communication, distinguishing risk from actual harm, and recognizing that improving the situation of people with least actually makes life better for all of us, whilst also acknowledging that all choices will have unintended consequences. But I think this is one of my favorite quotes about relationships from somebody who's worked in trying to improve wider society in the UK for a very long time. You know, why wouldn't we take a way of working and risk getting it wrong every now and again and having to, you know, say sorry, rebuild relationships, instead of doing what we know isn't working, that the more sort of structural, depersonalized solutions most of the time. So coming into a little bit more detail about relationship and relationality, those containers I talked about, I think again, perhaps we think unhelpfully simplistically sometimes, and we need to bring in these definitions. This is the one I shared with you earlier from David J. And he also talks about relationality, about the capacity of an environment to create relationship so that people can weave with intention, recreate, reimagine, invest in acts of love and courage, including instigating conflict that can be worked through. And of course, that means we have to have a much more complex view of what kinds of relationship may or may not be present in the places we are working. However, we do know that communities with good relational networks are better for everyone. And I don't expect you to be able to take in everything on this slide, but if anyone's interested, I really recommend the Relationships Project, which David works with, as a place to look into these things further about just how big a difference it can make in people's lives. So a good care system, or any system, is one with relationship as a first order goal, and it's about creating meaningful choice. And I know lots of people on this meeting with me, you already believe in it as a social justice issue, just as I do. But it's also a resource stewardship issue, an effectiveness issue. And I think that is really important for us to be highlighting to the wider system, so that when we come to think about relationship-centered practices, we are able to talk about these benefits, and it's not a nice added extra. It's something that could be fundamentally better for all of us. And coming back to that, systems hard to navigate. The way safety is created is coherent relationships, mutual understanding. And often that can start small. So asking one more question when you're in an interaction with somebody. I had an example of meeting somebody on a hospital ward, and they were really angry, and so was their son. And they were like, "You have come to tell me, you're another person who's come to tell me that I have to go out of hospital, but I know it's dangerous." And what had happened is that person had spent 3 months in hospital being told he was at really high risk of dying from a major bleed, whilst people work through investigations and treatment plans. And then the team had said, actually, we can't do anymore. We can't fix this. This person, so there's nothing more the hospital can do, so we want to discharge you. And they were surprised that he was saying, I don't want to go. I want to stay here. And we talked through it, and I said, okay, let's not talk about that. Let's talk about what you want to talk about. And of course, within 2 minutes, they were talking about discharge home, but their choice, their terms. And the patient's son said to me, I hope you don't think I was being too pushy. And I think this thing of, we put our roles on, we put our hats on, which Cara was talking to me about yesterday. And we recognize that we as people, but we also recognize that we have to work within the system, but often just asking that one more question, what's behind this? Why is this person like this? Is the thing that takes us to that place and actually can save time. I spent less time sorting out this why question than the team had. It's just I did it in one half-an-hour block instead of 10-minute blocks, that they were just at odds with each other. And so coming further to this whole system effectiveness issue, before, as some of you know, I came here, I spent some time in Alaska, working alongside people in the NUCA system of care. And they have really worked on trying to think, how do we make whole system effectiveness on a relationship model, focusing on, these are their statistics on the right-hand side of the slide. They're 20%, they use the term customer owners to mean their patients or clients. That's their chosen language. But the 20% with high intensity needs, and really looking at trying to make things structure less complex, not ask people to do added work that doesn't create value, often in the form of more forms to fill out. Looking at where high intensity resource use isn't actually meeting needs, and getting away from criteria-led services where people bounce around the system to more flexible services. So I was thinking, okay, fine, how do we think about that in relation to the population I'm interested in working with, those with severe mental illness who need palliative care? And of course, again, you will know that that this group of people experience a lot of stigma as well as everything else that they're dealing with from our systems. And I talked to the people at NUCA about this, and think it was really helpful how they talked about their philosophy behind the redesign. When they talk about outcome, not income, they're saying what's effective care, not how many episodes of care did we give. Person, not disease, or as one of them put it to me, distress, not disease. Being less rigid about precise diagnosis in a clinical sense. Population, not process, removing things that just kind of are extra referral forms, extra street screening forms, and bringing people straight into actually the added value work. And service, not practice, organising things around patient or client convenience rather than our convenience. And there were some real challenges to me about things that are just normal to me in my practice at home that I perhaps hadn't thought about questioning before. And this really speaks to the fact that we need to make solutions that are bespoke by design for people, not talking so much about diagnosing clinically, but recognizing and identifying to create understanding. So just to give you a bit more background about where I'm coming from, in the UK, there are 70 million people-ish, of which 600,000 are expected to die each year. Most would benefit from palliative care. 1 in 4 don't have access. And 500,000 people in England, we don't have stats for the whole of the UK, have a diagnosis of severe mental illness. They die on average 20 years younger than everybody else, and 1/3 of their deaths are from chronic conditions potentially amenable to palliative care, but they are much less likely to access it and much less likely to die in a hospice. They're much more likely to be admitted to hospital and die there. And when they're in hospital, to stay for longer than people without. And there is some early research that suggests more access could make a significant impact on that. And yet I, with a colleague, did a review back in 2023, and we only found internationally 4 studies of palliative care, including the perspectives of this group, which added up to about 30 people. So we know very little. We can understand very little from that. I'm afraid it gets a bit more depressing. There's intersectionality with pain control. Again, I'm sure you know this, that these is a population with high advocacy needs who don't necessarily interact and talk about pain in the same way as you or I might. and also that mental illness is higher in the UK in minority ethnic groups and areas of social deprivation. But we also know that people from ethnic minorities in the UK are less likely to get good palliative care, less likely to get pain control prescriptions, less likely to get the dose they need, more likely to have unplanned care. And so there are these compounding issues going on. And I think where we need to start is by attending to the stories and taking a relational approach. To continue the sort of nautical metaphors, course made good, you can't always go there directly. You've got to think about the wind and you've got to think about the current. You've got to try and avoid the whirlpools. And this means thinking about stories and really bringing into a transparent discussion how things are really constructed in the world. It's not all about just numbers in terms of any of our choices and behaviours. And the stories we tell can work with us and also against us. They can help us deal with things, but they can also, particularly when they're implicit and not voiced aloud, alter our sense of good and bad and how we act without us necessarily realising it. But I love the work of Arthur Franken, and he talks about letting the stories breathe. And I wanted to give you one more example that I found quite inspirational from being in Alaska. And they have a program where they talk about focusing on story. It's not a clinical program. It's about helping people resolve past issues through story. And this is the approach they try to take through the different sessions that they run. These are the things that they're reporting as impact. So without talking about clinical things, without any clinical intervention, this is the kind of difference that they're seeing. It's called the Family Wellness Warriors. That's what FWW stands for. And you think, okay, so they've managed to create some numbers too, and these are things that we want to use. And so this is something I'm really interested in exploring further. But to come back to my work, I thought it would be helpful maybe if I shared a couple of stories with you. And I've been sharing these with colleagues to try and build kind of awareness of what's happening. And these are the questions when I'm trying to share it as an educational presentation that I share with people first. And I say, take a picture of this slide, and then I'll tell you the story. The first one is from a gentleman who I met in the community who had been diagnosed. He was in his 70s. He'd been diagnosed with severe mental illness back in his 20s. So he'd lived with it for a very long time. And this is the picture he drew of who he was connected to. And it looks pretty good, doesn't it? However, when we analysed his story, these are the words that came up most in his story. And you can see that this tells quite a different story. And for time, I won't tell you the whole story, but I wanted to highlight how he was reflecting on, he tried to do the right thing. He felt judged. He felt that he was being judged for mistakes. He had cancer. He understood his situation. But he felt that every time he went and met with healthcare workers, they did things that triggered certain behaviours, which he attributed to his own mental health. And he was talking about being in pain and just being left there, and how this, he recognised, he had insight, this got them into a bad spiral of interaction with each other. The second example I want to share is a woman who I went to interview because the palliative care team had recruited her for me, and she shared her whole story around her palliative care needs. And then she said to me, oh, but the reason I volunteered for the interview is I look after my son with severe mental illness, and he had become psychotic during the pandemic. And what she actually wanted to tell me was a story of how she found looking after him. And again, this is her word bubbles, and you can see knowing people was very significant in her language. But the biggest challenge she'd faced was that she was asked to make sure to basically do a suicide watch for her son at home. He lived in the basement flat apartment of her house. But she was told she couldn't have any information about his condition because he didn't want her to know. And she's like, they're asking me to be in the team, but they say confidentiality means I can't be told anything. How am I supposed to work in the blind here? And so often for both people who are receiving care and those supporting them, they're sailing, and excuse the pun if you don't like puns, seven stormy seas around how care is constructed and how they're positioned. They feel like they're in uncharted waters, and they can feel like they're navigating in the dark or chasing mirages on the horizon. And I worked with some of these people and an artist, Daniel, to produce pictures that represented these feelings for them. And I'm just going to go through these slides for a moment or two and let you see the kinds of things that people said as we created this work together. And so that perhaps just gives you a little glimpse of where the people I was working with were at. And what we wanted to do was to develop this different metaphor, this different vision of care. And we started talking about living in an archipelago, an open ecosystem of islands, and drawing on this idea to get ourselves out of talking about the problem to trying to think about solutions. And the way we did that was we said, okay, we want to discover things, we need to be creative. And we talked about becoming lifeboat crew. Everyone from the island might be called upon to be the lifeboat crew. And how could we remodel healthcare in this way? How would we navigate? What could we learn about form and function? How could we aim beyond safe to good? And how could we make it equitable? And to start with, how do we develop a shared language? Because without that, how can we have shared understanding or meaning? And how can we get to shared practice? So going back to my ethnography, I worked with this group of people and we used something called activity theory. This is another methodology slide that the researchers I'm happy to chat to you more about at a later point. But all you need to really know is it was trying to look at people within a system. And what we did was we had a series of workshops where we talked about the different experiences people were having. How did we get to where we are? What were the challenges? What were the ideas? What were the possibilities? What would a dry run look like? What was the vision we wanted to create? And then we took this framework and modified it, saying what's happening in the system, what have we identified, what's working, what's failing, where are the tensions? And you can see some examples there of things that we noticed, which I've already mentioned. Where are the good bits? And oh, what would the good bits look like? And again, people weren't short of ideas. But where are the queries, the things we're not sure about? And I think it's really interesting. Forgiveness comes up here. And also, what are the real alarm bits and isolation and the stuff? And that is, we've decided, the technical term, because no one has a better one that captures it, that holds everything together. So we then picked on some of these things a bit more, and this is where the idea I mentioned about good practice versus just avoiding doing wrong and permission, knowing what you can do, came out in our further discussions. And people developed real empathy for each other. We lost the them and us by session 2, if not halfway through session 1. Everyone was talking about we understand, and actually it was a carer who here is acknowledging how it can be difficult for workers within the system to make change, as well as acknowledging that carers maybe could be freer to ask for more, but they don't have the inside information about how systems work. And so we tried to tidy up that really busy mess a little bit and make it a little bit neater, and really focus on what is shared dialogue here and how do we relationally create safety. And this is a quote from a mental health doctor talking about how they had managed to work with palliative care to give somebody a good death by not being concrete, by being flexible, working outside the box, forgetting the criteria and thinking about the individual. So then I've come on my Churchill fellowship, and really I'm here to learn from all of you, and as well as the other places that I'm visiting. And it's to try and build on these ideas and gain from people's experience elsewhere in the world. So this sort of setting sail, not safe but good. Where do we start? How do we, have boats, bridges, build those connections, but build them in a way that is relational? Or if you're in Alaska, maybe a seaplane is what you need. And people are already doing this, I would like to think I'm trying to do this in my own practice. And the words on this slide come from a mental health nurse talking about how she tries to pick up on flags and signals in the system, and what she's working with, trying to be that human connector, but with a depth of relationship in the system. And so we use the phrase relational glue to talk about support constructed between people, and relational reach to describe bridging work across the system. And we talked in the group too about different dimensions of functional proximity. And this might be partly an effect of some of the research was during our lockdowns in the pandemic. But actually, whilst co-location and geographical physical proximity is really good when you can have it, there are other ways of being close to people, and these other elements are also important. Pure physical proximity isn't enough for people to really be in relationship and feel supported. And so we started using the term collective social safety, and that's being safe with each other regardless of the situation. And I think to give you a non-healthcare example, I knew that I was officially a grown-up when I stood on a train platform in the dark and there were some teenagers messing around at the other end of the platform, or all kind of play fighting with each other. And then there was another teenage girl just stood on her own, and she came up to me and she said, "Can I stand next to you so they think I'm with you? Because then I'll feel a bit more safe and comfortable." And I was like, oh dear, I'm the grown up here now. But, that idea of being safe with each other, regardless of the situation we're in. And it's more than I'm aware that people have talked about psychological safety and, of course, physical safety for a long time, but it's not me as an individual, it's us together that we really wanted to emphasize from that piece of group work, ethnography. And that is needed for us to engage in experiential learning, and to develop effective needs-based care, because there will always be gaps between ideal care. There's a pragmatic gap based on resource that takes us from ideal to intended care. But then often there's a delivery gap between intended and actual, like how it works in the real work. And of course, people engage in hidden work. And I know Kelly mentioned, invisible work. I think what my research found was not just was some work invisible, but some work was actively hidden on purpose because people were afraid of declaring it in the system, yet it was also what was making good in the system. And we all need these basic needs to be met. I was looking for a Maslow's hierarchy of need diagram, although I don't really like the idea of hierarchy, and just stumbled across this one, which I think is much nicer and handily fits with my archipelago metaphor as well. But if the gaps are too big, we cannot cross them alone. We need relationships to help us. And we're going to meet some sea monsters along the way. And lots of you have already talked to me about how risk is viewed in biased ways. And again, I think it's how do we bring that relationship so that we can navigate this? Not trying to construct connectors that don't rely on people knowing each other, but instead creating inclusive containers where you have chains of people knowing each other through those multiple dimensions of closeness or proximity to get us through the risks. And of course, as we set sail and we start charting, we can make it safer. We can share the learning and improve the navigation, go from hidden to shared knowledge within the system. And that really means that we need to be attending to what everybody in the system's saying. And I love this quote, it's not about anybody holding the answers. It's about us developing shared understanding and then a real, genuine shared goal, and using that as the driver to work together. So putting on our boat shoes, or at least me putting on my boat shoes, these are the things that I am thinking about and how do I take them forward when I get back from my travels. Shifting from individual efforts to system ways of effectiveness, but keeping those relationships as formed chains of knowing. Not trying to control the sea, but to increase different forms of proximity, to define success as relationships producing good, not predetermined outcomes, and focus on needs-based care, not criterion-based services. And these are questions that I want to put to people who have some kind of decision-making capacity at home, and to be working with them on to try and make a start on this. Hopefully, this will be different ways that I can address that at different levels, policy, people, and practical actions. And I think referral management is currently top of my list, but also how much time do we spend on making relationships, as opposed to saying, oh, we're too busy to do that. And the 80-20 split is a really helpful way, I think, to think of that, spending 20% of time on building the relationship that makes the other 80% much more effective. That way, I hope we can reconnect islands and we can be thinking about how do we facilitate the social interaction that's needed to address all of these differences. And I've been learning loads from knowing you, meeting you, beginning to build our relationship. And there's just a very small list of things that I'm definitely taking away from Victoria here. I'm so grateful for the welcome you've given me and the way you're all helping me develop my thinking in this process. I'm going on to look at other places, if you're interested, who say that they have got ways of looking at organisational change and developing accountability. So I'm excited to take the real life stuff I've learned from you and see how it can challenge these approaches that people are using elsewhere. And just to finish, when people came to our art exhibition, we gave them postcards so that they could give us feedback. And if anybody wants to tell me your own thoughts, either in answer to this question on the postcard or anything else, that QR code just gives you a direct link to my email, and I'd love to hear what you think. And this is the ship's cat. It's actually a robot cat who one of the people I interviewed was given as a support for her husband with severe dementia. And I'm going to flick over that because I think we're out of time and stop sharing. But thank you so much for listening. And I hope it didn't feel too much of a whistle stop tour, although I'm aware that I've rattled through a whole load of stuff. But thank you.